and welcome everyone to the 2024 Mannion Lecture, a discussion on the Canadian healthcare polycrisis with Dr. Alika Lafontaine. My name is Vanessa Vermette. I am a Vice President at the Canada School of Public Service, and I'm joined by my colleague Nathalie Laviadès-Jadouin, also a Vice President at the Canada School. Together, we will be your hosts. We have a great event planned, and we want all of you to have the best possible experience, so please take a quick moment to silence your mobile devices. Today's event is in English with French interpretation, and headsets are available at the entrance if you need one.
So, without further ado, I'd like to welcome Elder Verna McGregor of the Algonquin community of Kitigan-Zibi Anishinaabe, who will welcome us to her traditional territory and open the 2024 Mannion Lecture.
Okay, now, bonjour tout le monde. Hello, everybody. I'd like to welcome you to our traditional unceded lands. What does unceded mean is that, amazingly, we never signed treaty connected to the land here. The significance of Ottawa for us, we're known as the Mamaninawag, which means the nomads, and we had big territories because of our understanding that if you stay in one area, you overharvest the resources. And interestingly enough, too, as well, we survived on the land, and that with the understanding also with the medicines which were land-based. And here we are today, too, as well, with technology and the poly health crisis, as we're talking about today. I'm very honored to be here today. I was thinking about the venue here. A couple of years ago, the CEO of the National Gallery met with elders, and they came up with the theme of Encosé, meaning everything is connected. And that's similar to, for us, with an example is the medicine wheel. And here the significance of Ottawa is that it's at the confluence of the four rivers coming together from the four directions. At the center represents balance. This also represents, too, as well, the four seasons, the four directions, but it also represents, too, the need for emotional, physical, spiritual, and mental health, well-being, because sometimes, too, as well, that translates into physical health. So at the center is balance, and I always find that interesting that Parliament Hill and all the national headquarters are situated here today at this confluence, and I think that's why Dr. Lafontaine's talk here is so important. Then going back to Encosé, meaning everything's connected, is similar to, this is a dream catcher, but it also represents the spider teachings. The spider weaves the web of life, and everything is connected and interconnected, including the healthcare system. So, and one of the biggest teachings is that what we do to the earth, we do to ourselves, and we always strive for balance. And right now, I think our healthcare system is out of balance. So I think this is such an important gathering. I'm just going to get my little, my eagle feathers, and I'm just going to say a little opening prayer for you to wish you well and a good gathering today. I was offered tobacco too as well beforehand, and this is part of our protocol because part of our creation story is this is one of the first gifts given to us. So anytime you harvest anything or someone shares knowledge with you, there's the offering of tobacco, and of course too as well with contact and colonization, this turned into a commercial good, and like any medicine, to overconsumption can cause harm. So on that note, I'm going to say miigwech, hojeni gashkito chuma ndose konshe nongo, mame kakina pamadze jekdenes wa konshe, widokwa kakina onje pamatsuin, enabiges miigwech onje kakina gagishen danonje mam deken in the kimenon, shkaki question kason in the kimenon, widokwa kakina pamadze jek onje nagadawabdan, kakina guch in the kimenon, miigwech onje kakina ete kishagon kises, to be kises a shitanang shak, widokwa kakina mam dege, nokamasnan, onje nagadwab dan kakina guchni bi, bigwech onje shkude, kagimijin, chiminobjatoyan, bigwech onje ya nasewen, kagimijin, chimino pamadsayan. We don't go kakina ninjino and doganag mom de gay, nitabano jishak. Kanshashquat negwe de simen kego gajemane doshech kana noj kuch negwe de simen. We don't go kakina mom de gay dashi akusajik. We wisnajik. We giwe jik. Ashich nongom we mi godwajik. Shwen mishno. Mi gwach. I just go around the medicine wheel thanking the earth and the all-knowing for us being here, but also too as well the four elements, the earth, the water, the fire, and the air, because without them we wouldn't be here. And I ask everybody too as well for well wishes for our gathering. And Mino Pimadiswin is well-being, and that's your learning word for today. So I wish you well. And we're going to quiz Dr. Alika afterwards too. No. Thank you, miigwech.
Thank you, Elder Verna, for your words of welcome and for opening our event by reminding us that at the end of the day, we are all connected. Now, it is with great pleasure that I welcome you all once again to the 2024 Mannion Lecture. I would like to offer a very special welcome today to Dr. Douglas Mannion, who is here with us. I believe you are, there you are, thank you. He is here with us on behalf of the Mannion family. Thank you so much for joining us today. I would also like to take a moment to mention the recent passing of an important member of the Mannion family. Last November, at the age of 90, Sylvia, or the matriarch, as the family called her, passed away peacefully, surrounded by loved ones. She was, among other things, a devoted mother, grandmother, and great-grandmother, an outstanding community organizer and social planner, and a volunteer who knew how to bring comfort to sick children in local hospitals. Dr. Mannion, our thoughts are with your family. So the Mannion family can take pride in the legacy of John Lawrence Mannion, the inaugural director of the Canadian Centre for Management Development, whose name is honored in this event. For over 30 years, the Mannion Lecture has been one of the school's most important annual events, and it gives us the opportunity to engage in dialogue with eminent speakers from different backgrounds, professions, and points of view. It gives federal public service leaders the opportunity to be challenged by other professionals who question the status quo, wonder about the future, and help us expand our horizons with their insights. Our keynote speaker this afternoon fits perfectly into the Mannion Conference tradition.
So in just a moment, we will introduce our lecturer, Dr. Alika Lafontaine. Following his lecture, he's going to be joined on stage by a panel of distinguished guests to continue the discussion. After the panel, we will be ending the formal program with a traditional closing provided by Elder Verna McGregor. And then finally, we invite you all to join us in the foyer for a networking reception once the event program is complete. So we would now like to formally introduce this year's lecturer, and this is going to take a while, so this is your trigger warning if you've ever had like imposter syndrome or anything like that, because this is a highly accomplished person we have the privilege of having with us today. Dr. Alika Lafontaine uses his political capital and influence to create spaces where Indigenous communities can collaborate with physicians, politicians, and policymakers to improve Indigenous healthcare. He is an award-winning physician and the first Indigenous doctor listed in Medical Post's 50 Most Powerful Doctors. From 2013 to 2017, Dr. Lafontaine co-led the Indigenous Health Alliance Project, one of the most ambitious health transformation initiatives in Canadian history. It involved Indigenous leadership from more than 150 First Nations across 3 provinces. For the last 2 decades, he's served in a variety of medical leadership positions with the Alberta Medical Association, the Canadian Medical Association, and the Royal College of Physicians and Surgeons of Canada. He also served as Vice President and President of the Indigenous Physicians Association of Canada. After being labeled with learning difficulties as a child, his parents made the decision to homeschool him. At the age of 16, he became one of the youngest recipients of a prestigious NSERC fellowship through the University of Regina. After graduating with a BSc in chemistry, he completed his MD at the University of Saskatchewan, followed by a 5-year internship in anesthesiology. During his internship, Dr. Lafontaine won CBC's Canada's Next Great Prime Minister competition for his platform on the importance of treaty implementation in strengthening relations between Indigenous peoples and Canadians. Yeah, let's clap for that, absolutely. In addition to many other awards and distinctions, he remains the youngest recipient of the Inspire Award, which is the highest distinction awarded by and for Indigenous peoples. In 2015, he also received the Young Leaders Award from the Canadian Medical Association. Dr. Lafontaine continues to practice as an anesthesiologist in Grande Prairie, where he and his family have lived for the last 10 years. He was born and raised in Treaty 4 territory in southern Saskatchewan and has Anishinaabe, Cree, Métis, and Pacific Islander ancestry. It's an incredible journey, and we're deeply grateful that he's able to be here today with us. Please enjoy a short video and then join us in welcoming Dr. Lafontaine to the stage to begin this year's lecture.
Climate change, the housing crisis, food insecurity, widening socioeconomic disparities. This intersection of multiple crises is called polycrisis. A polycrisis stems from the activation of a particular kind of risk, systemic risk, by which a small problem quickly spreads throughout a system and often into other systems. Global reports say that the polycrisis is here to stay. Is the public service ready?
An adaptable system is one that is capable of transforming itself to meet new challenges. Adaptability is essential if governments want to retain authority and legitimacy in a turbulent and often dangerous world.
How can the public service adapt to the challenges of the polycrisis, which are already placing a tremendous strain on Canadians? What strategies can we take to move forward?
Figuring out how we do things in a new way, figuring out how we manage the risks that are in front of us, acknowledging that this is hard, being innovative and collaborative. I think that gives us the best shot we have.
In this year's Mannion Lecture, special guest speaker Dr. Alika Lafontaine, an award-winning physician and past president of the Canadian Medical Association, will examine the changes taking place in the Canadian healthcare system and their impact on our social cohesion. Drawing on his personal and professional experiences, Dr. Lafontaine will discuss the human experience of systemic change and how changes to public health policies are enabling citizens to better manage their own interests. Welcome to Mannion 2024.
It's an absolute pleasure to be here tonight. Out of all the different types of lectures that I've been a part of, I've really come to enjoy interacting with the public service. There's a lot of thoughts out there that the way that systems change is through marches or protests or breaking systems or, in some cases, lighting them on fire. But the reality is change is a grind. And for those who've been in the public service for enough of your career, you realize that with the peaks and valleys, you still remain. And so I'm really hoping with the topic today that I'll help to share a bit of my own experience and ground you in a way of understanding the very real and very big and complex entrenched problems that we deal with nowadays. This lecture is also really special because my dad's in the audience today. Like most dads, you give him a call and say, hey, I achieved this thing. And he kind of shrugs his shoulders and says, oh, that's nice. And I think having the person who first taught me how to think through complex, challenging problems really brings a lot of my career full circle. And my dad was one of the first people to have me think about my life as a story. And I think when you look at polycrisis, just like anything, it ends up being a story that we tell ourselves. And the stories that we tell ourselves they really set the way that we interact with the world. And stories shape how we see ourselves. When you go into work, there's a story that you tell yourself about the change that you're going to be able to make that day, about whether or not it's going to be a hard or an easy day, the meetings that you have with people, our projections on how stories shape how we see each other. And stories really ground us in either feelings of hope or feelings of despair and isolation. And I think especially with Polycrisis, it's incredibly important to have those stories ground us in a place that helps us move from where we are right now to where we need to go. All of these polycrises are probably no surprise to the public service. Each of you are probably on teams where at least one time during the week you hear or think about these problems. Climate change has affected where I live in particular. In Grand Prairie, Alberta, which is 4 hours north of Edmonton, we had a fire that was burning 30 kilometers away from us for a few days, and it was out of control for most of it. Luckily, the winds were blowing away from the city, and rain came for the past couple of weeks. But I found it interesting that when we first had forest fires, we were all quite terrified about what happened. Now we have a bit of a protocol. We went and grabbed our air purifiers, and we set them up in the house. We turned off our ventilation to make sure that we had a bit of a sealed system. We packed our 5 days of clothes, filled up the van, and went to work. And I think with any type of crisis that you're dealing with, eventually you start to get very used to the reactions that you have. Now in healthcare, crisis that I've been a part of quite deeply over the past 3 years, we know that we truly are in a critical moment right now for our healthcare system. 6 million Canadians are without access to primary care. That's 1 in 5, depending on which studies you look at. There's rolling or permanent closures of a lot of healthcare services. In the pandemic, we really saw a pullback of services, rightly so, because of dealing with an unknown pathogen that was spreading across the system fairly rapidly and causing widespread injury and morbidity. But we're also seeing kind of a tail end of that, where now emergency rooms are closing, surgical services are closing. That's lengthening the access to a person actually seeing someone who can deal with their problem, whether that's access to a certain type of testing or some type of medical procedure. And we're also starting to see crumbling infrastructure, not just among the people who fill and ensure that people can get pushed through the system as they get the care that they need, but also our hospitals and other types of infrastructure are starting to wear away and at times actually crumble. Now, I've had the opportunity with the Canadian Medical Association presidency to really tell stories at scale. And for 12 months, I was Canada's top doc. I was on TV probably every night for a period of that time. And with the different crises that were emerging, the biggest challenge that we actually had was how do we weave together all of these things that seem disconnected, but at the end of the day, probably aren't. And I think when you look at Polycrisis, that's one of the most important parts of understanding the story. Climate change led to the evacuation of patients from Northwest Territories to my hospital and other hospitals in Northern Alberta and Northern BC. The lack of housing impacts the opioid crisis, as well as your ability to have people go to somewhere safe where they can continue to be on their path towards better health. The lack of affordability leads to patients realizing just how desperate of a state they're in when they truly are sick. Mental isolation and our mental health crisis all feed into all these other things. And Polycrisis spins round and round until the small problems that used to be solvable, stories that used to be easier to understand, suddenly become incredibly complex. So this talk is going to be split into 3 parts. I'm going to focus mostly on the first 2, and it's going to talk about the physics of storytelling, using a model where we look at the weight of the past, the push of the present, and the pull of the future. This comes from something called the Futures Triangle. It was developed and has been used for the past 20 years, but it's a really great way to really help to understand where you as the public service can make an impact and help to frame why change ends up being so hard, especially in the midst of Polycrisis. So starting off with the weight of the past. So the weight of the past is something that we end up inheriting. It's not something that we create. When any of you have moved from department to department, You know the feeling as you walk into your office or open up your portfolio and for the first time see everything that came before you got there. Those are the histories, the culture, the good and bad decisions, relationships that people have with each other, the ways that physical and digital infrastructure is organized. In healthcare, there is a heavy weight on the past because our system was really designed around things that weren't necessarily structured in a way that matches the world that we live in now. So I'm going to do a quick exercise with all of you. I'm going to ask you just to count some F's in a paragraph. I'll throw this up in just a second. I'm going to give you 3 seconds. I'm going to ask you how many F's you've counted, so maybe just wait until I ask you, but we'll put that up right here. So here's 3 seconds, 1, 2, and 3. And I'm going to ask, how many people in the audience saw 3 F's? Can you just raise your hands up high? Okay, it's a fair number. How many people saw 4? It's always interesting, the people who saw 3 get very concerned once they see people saw 4. And then how many people saw more than 4? All right. So there's actually 6, all right? So I'll just read them out here. Finished files are the result of, that's 3. Years of scientific, that takes us to 5. Study combined with the experience of years. Now, I presented this many times over the last few years, and the larger your audience, the more you tend to migrate towards kind of a common set of responses, kind of a normalized distribution. So about half the folks in the audience, which I say was pretty similar to the people that raised their hands, see 3 F's, about a quarter see 4, and then a quarter see more than 4. Now, I'm going to suggest that if you have a similar reaction to other people, and time-wise and location-wise, that response is independent, there's probably a way of thinking about things that we share, all right? So when we talk about these ways of approaching problems or thinking about problems that are similar, we can give them a label, and I'm going to give the label of mental models. So with the exercise that I just presented, there's a set of common things that people tend to say for why they read the paragraph that they did, the way that they did. The first is that you read for content. So although I gave you the task of counting the F's, most of you were probably wondering what the paragraph was actually about. The second is that when you're limited as far as time, you tend to skim. So large words mean content, small words mean filler. The last is that you tend to read aloud. So the sound of scientific in your head sounded very different than the sound of. Now, with any way of thinking, there's always people who do not think that way. So for whatever reason, if you never graduated high school past grade 4, these folks tend to not get tricked by this exercise. I'm not sure what you learned between grade 4 and grade 5, but there's something out there that kind of centers on that. The second is that if English is not your first language, meaning that when you read something, you translate in your head to your language of origin and then translate back, for whatever reason, this doesn't work either. So I'm going to give you one more exercise here. I'm just going to have you read these triangles. I'm going to throw this up. I'll give you 3 seconds again. So I'm going to count to 3 here. 1, 2, and 3. I'm going to have you read them one more time. How many people saw the trick, and how many people did not see the trick? Raise your hands if you did not see the trick. This is actually the exact same mental model. There is no difference between what I literally just explained to you and what you experience right now. And this is a really important concept when you're thinking about the weight of the past. Is the weight of the past are really a collection of mental models that have normalized what you experience day to day in the things that you're trying to change. They're often shared beliefs. These are often rooted in childhood experiences, traumatic experiences that you might have had with relation to what you're thinking about. They signal how to act in a socially acceptable sort of way, which means that they don't actually have to be true, they don't have to be logical, and most importantly, they actually don't have to be adaptive, which means that you can believe something that has you act in a certain way that doesn't help you get to where you need to go. For example, with the paragraphs, the way that you read the F's, I gave you the task of counting, but instead you wanted to know what the paragraph meant. It was a maladaptive way of thinking about things. The interesting thing about mental models is that if you change a mental model, you almost always change behavior. All right, and I say almost because I'm a scientist, but I would say that I've actually never seen someone not change their actions as a result of changing their mental models. Now, mental models can be abstract or they can be concrete. All right, so I'm sure many in the public service have gotten familiar with certain files where you kind of pick it up and you read through it and you're just like, I just don't get this, right? Or you hear an announcement or become a part of a program and you say to yourself, I just don't know what this is about. I don't know why this matters. Why are we using resources in this area? All right? When you can't explain a problem, that problem is abstract. Now, as you get less abstract about a problem, you start to understand that the problem's actually out there, but the problem is not where you are, it's everywhere else. All right? So if you ever come into an environment where the majority of people are talking about a problem that needs to get solved, but folks are talking about that problem in the sense that this is a problem everywhere except for here, you're getting less abstract than being unknowable, but not concrete enough to actually start to solve them. Now, once you start to see that the problems out there are the problems in here, you start to get on the concrete side of this continuum. Now, even though you know that these problems are here, the issue is you still don't know how to solve them. Now, the ultimately concrete problems are when you know that things are knowable. All right, when you sit back and you see a problem and you can break it down into three parts. You can explain it, and with that explanation, you can predict where it's present and where it's not. And with that prediction model, you can then dial up or down different elements in order to make the problem worse or make the problem better. Now, in healthcare, we have a lot of abstract discussions about problems that we actually know are quite concrete. With the health human resource crisis, for example, there's often the discussion that we don't really know how to solve the problem, this is a brand new issue, et cetera, et cetera. For anyone who's ever been recruited into an area, it's very concrete to them why they came. We came to Grand Prairie because I wanted to get away from academia for a little bit. I stayed because it was an amazing place to work with people that I knew would show up if I called them. And we started there for 2 years and ended up there for 12. So I'm going to explain to you some mental models in healthcare design. I'm going to try and do it less than 10 minutes. I would just warn you that this is a very simplified way of thinking about this. Those of you with deep knowledge in healthcare will be able to add a little bit more to the story, but just for brevity, I'll be simplifying it. So with any thriving society, you really need a couple of components. You need to have a way for people to exchange value. We call these economic systems. And you need social cohesion, a way for people to be sticky enough with each other so they actually solve problems with each other. Now, if you think of society as soil that's fertilized with these elements, if it's fertile enough, you can actually grow certain things. And so this is where our shared social systems come from. This is where our health system, education system, justice, and housing systems come. But with those elements, there's booms and busts that occur. And the soil that these systems grow in eventually become arid and dry and just not great to grow things in. Now, if you leave these for too long, the systems start to wither. And in some cases, they actually start on fire. Now, I actually argue that much of the systems that we have nowadays in the federal, provincial, and territorial governments are in the area of actually being on fire. Now, if you look at the brief history of Canadian healthcare, you can start to understand how we got here from knowing where we started. So before 1947, when Saskatchewan first came out with its first attempts at public service or publicly funded healthcare, the healthcare system was really a mix of nonprofit, for-profit, and charitable approaches to healthcare. There was just a very, very small sliver that existed as publicly funded and publicly administrated. Now, because of an economic issue that Saskatchewan had, I'd argue, the Saskatchewan government decided that it was going to fund public health care. So in the 40s, farmers and other folks who were participating in the Canadian economy were getting sick. They were going to hospitals. They couldn't afford care. So as a result, they were going to the charitable and nonprofit section of care. That was under-peopled. It was under-resourced. And people weren't just getting healthy enough to go back and work again. And so as a result, the Saskatchewan government actually saw that if they didn't do something about it, the system would continue to spiral around and the economy would probably crater and crash. Now, I think in retrospect, we often try and rewrite history as far as the reasons why people went about doing these systems. But if you look at the original debates around healthcare, a lot of the discussion was actually grounded in this economic viability. If they did not solve this problem, then Saskatchewan society would actually fall apart. So Canadian healthcare then was initiated, and from the 50s to the 90s, there was a period of growth. All right. Now, with this growth, the approach was simply to mirror locations. So if you had a small community hospital that had a doctor, a couple nurses, and a few support staff, you would simply duplicate that number of people and bring them closer and closer to where people actually lived. People weren't very mobile at the time. If you weren't able to drive around, which was expensive and out of the reach for the average person for the most part, you just didn't receive care and you ended up passing away. So from the 50s to the 90s, you had a spread across different systems. Saskatchewan's actually a really great example of this, where the healthcare system went into more than 50 small towns in the periphery of the major centers, which were Regina and Saskatoon. Now, once you hit the 90s, there was a resource limitation that occurred. So people realized that we can duplicate the number of places where people can access care, but the challenge is there's not enough people to actually duplicate. It's really expensive to build a new location, and it was restrictive financially to actually buy new CT or MRI machines or other types of specialized equipment. So from the 90s to the early 2010s, the system started to regionalize. And this has happened at different rates across the country. Ontario is probably one of the last places to adopt regionalization. But in Saskatchewan, what ended up happening is instead of being able to access anything at any hospital, no matter where you went, you started to have one trauma hospital. Instead of having a psychiatric ward in every hospital, you ended up having to go to a single one. And so with this regionalization, people also became much more mobile. And so although you had more limited options in where you could go, people were able to get up and travel from place to place. And so you started having people move from jurisdiction to jurisdiction within provinces and territories in order to access care. Under Minister McKinnon, who was the finance minister in Saskatchewan at the time of this happening, there was a big push with regionalization to actually shut down access locations. And in the late 90s, early 2000s, there was the closure of more than 50 hospitals or mini hospitals within Saskatchewan towns to the point that people actually had to go to Saskatoon or Regina for care. Moving into the 2010s and 2020s really becomes the age of austerity. So the major message from governments was that we have to bend the cost curve. Sustainability is a huge issue. To be fair, GDP was definitely, as far as the health proportion that was being used, was moving into the 30s and 40% of overall budgets. You end up having the pandemic, which has now pushed the efficiency balance that really happened between the 2010s and 2020s into the critical situation that we're in right now. Now, if you look back across that history, I'll actually argue, after having lived with these problems for quite a long time, that there really was just three things that we were trying to solve. The first was access, the second was complexity, and the last was to have high value. So if you look at the sticky problem of poor access, the mental model that we've used over the last 60 years is really just build new access. If you can't get access to care, what do? You build a new hospital, you build a new access location. Even now, this has just been rewritten in different ways. In Ontario, for example, if you can't get access to surgical care, what do? You go to a non-hospital surgical facility. If you can't get access to primary care, we've now expanded the number of people that we label as primary care providers, which is really just increasing and creating a new access point. With rising complexity, you move towards new specialization and more training. When I sat on the council of the Royal College of Physicians and Surgeons, which deals with specialty training across the country, every month there would be a new application for a different type of surgical or medical specialty in order to deal with the changes in how people practice. When you have low value, it was really new metrics and new technology. You create new ways of counting things, new types of ratios. You would have people adopt new types of technologies in order to have people communicate faster, be able to track more easily. Now, past problems and past solutions have become our new challenges, in my opinion. So with poor access and building new access, our current challenge right now is actually fragmentation. So when you look at the numbers for family physicians across the country, for example, there's 3 different sets that we used at the CMA in order to count them. The people on the lists weren't necessarily practicing longitudinal family care. In one of the sets, a Canadian family physician who was actually an astronaut in space at the time that was counted realized he was actually on the list. I guess he could have provided virtual care, but we don't know what people do. We don't actually know where they're at, and we can't agree on how many people are actually present. If you look at rising complexity and new specialization and more training, there's really been a loss of general skills, and to a great degree, over-regulation of a lot of the ways that people train. When I was in Grand Prairie, when I first moved there, we saw that there was an issue with people getting access to sleep medicine services. Myself and another colleague went away for 3 months of training. We provided the service for a couple of years. They brought in a new rule saying that we weren't allowed to do that unless we took a 3-year residency. Neither of us were willing to do that after being in active practice. Now we have people with 1 or 2 years training in kinesiology or some other specialty providing sleep medicine services, while myself, as someone who actually manages airways for their living, can't provide this type of service. When you look at low value, with new metrics and new technology, manipulated metrics and uneven adoption are very, very common across the healthcare system. It's always very surreal for me to sit at the front desk as I'm responding on my secured, managed electronic device in Alberta's pan-provincial electronic medical record system, sending a message back and forth to make sure that patient information is protected, and I can hear the fax machine moving in the background. So as you go through cycles of having the same solutions and polycrisis, these problems actually start to mix together. So with building new access, poor access and fragmentation have actually become very similar in the discussions and with the ways that we kind of frame these problems. And as these problems start to stack, complexity starts to get harder. Things get more entrenched as far as problems that you're trying to solve. And as a result, you move towards what I call critical failures. So because of these stacked problems, broken patient flow is probably the biggest critical failure for folks trying to navigate the healthcare system right now. You ask the average Canadian, do you get access to a family doc? Even if you're attached to a family physician, you still have to go through multiple doors to figure out whether or not you can get the care that you need. When people migrate to emergency rooms in order to try and get care for a problem that they have, the reason why they go there is because they think that that's going to be the person that they need to talk to. And so broken patient flow is the end result of these stacked problems of building new access. For new specialization and more training, we have inaccurate predictions as well as broken HHR strategies. I will say that the predictions that we've made in every area of healthcare, whether it's for spending or for the numbers that we need to train for physicians, or the ratios that we have for nurses who are working in the healthcare system, they've been wildly inaccurate. I think that most of the reports have actually been so inaccurate that following the reports themselves has actually become one of the big problems. With the mental model of new metrics and new technologies, the critical failure has been exponential costs, redundant care, meaning that you go and see someone, they charge for care, but they don't actually fix any of your problems, and then worker burnout, which is a rising and escalating issue that I heard lots about during my time as CMA president. Now, these mental models and stacked problems go round and round in cycles as these critical failures get worse and worse. And for those of you in the public service, I can imagine that it's incredibly frustrating to sit there and try and deal with these problems and feel like no matter what you do, nothing ever gets better. So how do we break this cycle? So like I said at the very beginning of the talk, everything is a story. And the essence of any crisis is a story. And it's understanding the right types of stories that lead you to different types of solutions. This brings us to the push of the present. So the push of the present is what pushes you in a direction of telling a different story or reconsidering that the story that you've been following isn't really grounded in something that's practical, pragmatic, or getting you closer to where you need to go. So the push of the present can be split into social drivers, technological drivers, economic drivers, environmental drivers, or political. And I'm sure all of you have felt these at some time during your career. So if you look at the push of the present and you apply it to the way that folks experience change in the healthcare system, you can use something called the Kubler-Ross change curve, which I think most folks have come across at some point during their training, which is really a way to understand the stages of grief as people go through system change. You start off with a status quo. That leads into a crisis because your status quo doesn't work during that time. That leads to people to reconsider whether or not things are working the way that they want. That pushes you into this denial phase where people push back at the change that's suggested. That drags you into resistance and then moves you into exploration, commitment, and a new status quo. Now, understanding where people think change happens is really important in understanding why it doesn't. So most people focus, when they're trying to explain the human experience of change, on exploration, commitment, and a new status quo. How many of you have written calls to action? How many of you have had strategies to try and socialize those calls to action, to really push people to consider adopting your 10-step method of changing the world? Now, change actually happens at the front side of this model, with your status quo, your crisis, denial, and resistance. Crisis is the result of maladaptive status quos, as I mentioned. Denial is the intuitive pushback that people have when they feel like their mental models are not consistent with the actions that have been suggested. Resistance is when we try and reallocate resources between one place versus another. And the reason why there's such a huge dip in support for change and a peak in the opposition to change is because when you reach into someone's pocket to take out a resource, or you fire someone from a team, or you tell someone that they'll have a new boss, they will die on that hill. While with denial, they're pushed until it's not worth it anymore. So change doesn't happen because we stay trapped in this circular failure for change because we never get past denial and we never get past resistance. Our weight of the past is really our status quos, our denial and resistance. The only push of the future is the crises that we're trapped in. So many of you may feel, when you hear about crisis, the urge to de-escalate and minimize the crisis that is present. That is actually helping things stay the same. Crisis is the only fuel that leads to a reconsideration of entrenched status quos. So just in summary, all mental models that I've talked about likely worked at some point. I'm sure you can appreciate that when healthcare was first being organized, the approaches that we had to access, complexity, and value actually made a ton of sense. But when they became maladaptive, when the world changed, they started to generate crisis instead of generating solutions. Every mental model that you come across is maladaptive in some context. Crisis is the fuel for transformative change. Embrace crisis as an opportunity for you to change things. Crisis is what pushes us together. What causes people who otherwise would be on two far sides of a discussion to actually sit down and decide to work together. With the weight of the past, the push of the present, and the pull of the future, cycles of entrenched crisis make it increasingly difficult to make changes as you move round and round. Change means changing our shared beliefs enough to meaningfully shift who gets resources and who doesn't. But those beliefs have to match the world as it is versus the world as we think it is. The public service is probably one of the most important groups that really needs to figure this out. You are the glue that helps us grind through these long-term problems. You're what survives political cycles. You're what survives schisms between political groups and demographics. You're who's left to pick up the pieces when provinces and territories fight with the federal government or with each other. There is a bright future, I think, for dealing with polycrisis, but it really comes down to the stories we tell ourselves. And importantly, most importantly, I think, the stories that you tell in your day-to-day work. Thank you very much.
Thank you, Dr. Lafontaine. I've had the pleasure of watching many of his events. I've had a greater pleasure in moderating one event directly with Dr. Lafontaine, and every time I'm left both speechless, in awe, and always with an important takeaway. And today, the frame that you presented through which we look at polycrisis around the weight of the past, the push of the present, and the pull of the future, I think has tremendous relevance for us in the public service. So thank you very much. So with that, it's time for our panel discussion. So I'd like to first welcome our moderator, Taiki Sarantakis, also president of the Canada School of Public Service. Yes, good time. And joining Taiki are very esteemed guests. So starting with Dr. Douglas Mannion, who's the CEO of Flare Therapeutics. Dr. Anye Noram, co-founder of the Black Health Education Collaborative, assistant professor at the University of Toronto, and the host of the Race, Health, and Happiness podcast. Now you may. I'd like to welcome as well Cameron Love, who's the president and CEO of the Ottawa Hospital. Dr. Zaina Kayat, health futurist from Deloitte, Canada. And rejoining us, of course, our Mannion lecturer, Dr. Alika Lafontaine.
All right. I wonder if that's me. I always have problems with these microphones. So, Dr. Lafontaine, just remarkable. And it's really an honor to have the opportunity to explore some of the themes that you talked about in the next half hour or so. So, every good panel starts with a confession. So, we're going to start with a confession. I am the token dummy on the panel. As you may have noticed in the introductions, everybody here is a doctor except me. So please forgive me because I know not what I do. So we're going to start going to go around the table in order. So Zaina, I'm going to pick on you first. We've also decided, since I'm not a doctor, that we're going to use first names instead of doctor. So, Zaina, I've known you for a few years. How'd you come to the school relatively early in my tenure at the school? Because you were like one of these very cool, techie people. And I remember you talking a lot about AI and healthcare. And it seems so long ago. It seemed like healthcare was in a better place back then, and I don't know if it's a story that we tell ourselves that healthcare is getting worse or healthcare is getting better, but maybe if you could kick us off a little bit with healthcare and technology vis-a-vis how you see things.
Yeah, so I mean, I've evolved my story as well. So here's the story that I'm sticking to, at this point. Healthcare is a labor-intensive sector. It's 75% labor. Okay, that's 75% of 12% of our GDP. It's the most labor-intensive core sector in the world, more than agriculture, mining, anything else. Yet it's an information-intensive thing. And I honestly think we don't need the labor, the humans, to keep doing these things. So technology replaces labor wage. That's all technology does. That's all it's ever done. And I think that's why we've been trying to get the promise of freeing up these precious, incredibly trained humans to do what only humans can do and do it well, and then let the technology do all the riffraff. And I think we're now finally at a precipice with this word AI where we're actually going to start to see some of those returns. And those stories are being shared right now at the National eHealth Conference, including one I think my firm is doing with Ottawa Hospital, where we're using AI to give leverage to humans. So I think we're through the mucky muck of digitizing, and we're going to start to see the value from technology finally in healthcare, but not fancy tech, just software.
Now, Cameron, I want to bring you into this in a weird way. So you are the president of the Ottawa Hospital, which means you're running a hospital, but you're also building a hospital. So I want to talk to you about both of those things. First, running a hospital. I can't imagine a more difficult job in 2024 as we see crisis after crisis after crisis in our emergency rooms, waiting lists, etc. It seems to me that we as a society are now putting a lot on two different groups of people. One of them seemed to me to be healthcare workers in general, but emergency personnel in particular. And then the second are police officers. They both, to me, seem to have become almost de facto social workers. Talk to us a little bit about your experience in the emergency room running a big organization, which is the Ottawa Health.
So you chose the easy question.
Yeah, exactly.
So I think, and maybe I can go back a little bit. If you go back pre-pandemic, go back 10 years, this has been a problem that's been building for literally a couple decades. And I think what we're starting to see more and more is the emergency departments have become the de facto for where people get care because we haven't created the capacity outside the hospital in some integrated way to support people before they need hospital and definitely after they leave hospital. So in the absence of that, what you get is everybody coming into the emerge department. And I think it's a growing problem. I think you also have, if you take Ottawa, it's a growing population, it's an aging population. So by default, with the lack of primary care that's evolved, primary care does not necessarily need to be a physician, it needs to be organized primary care to support people, whether it's in their home or whatever care they require. We don't have the proper bedded capacity that we need for people. We have more than enough acute care bed capacity. We don't have capacity in the community to support people when they leave the hospital. And so what ends up happening as the growth in the system builds, and we've seen a lot of that impact coming post-pandemic, physicians, nurses, orderlies, like they are incredible people that are 100% dedicated to making sure. And that's why emerges function for the most part. I thought Alika's summary is bang on right. You're starting to see rolling closures of emerge departments across the country, across this region, because the smaller ones that don't have the same infrastructure, all it takes is one or two people to be off and you just can't run the service. And so I think what we have to start to continue to evolve on is building capacity in the community. It's not about the hospital. It's about building capacity as a healthcare system in the community, which ironically, if you get that right and you start to build that way and you integrate it, you start to decant the emerge department. But in the absence of that, we just continue to see more and more growth within emerge departments with volumes because we haven't built the capacity before and after.
And Anya, in addition to the other hats you wear at the University of Toronto as a professor, as a podcast host, you're also a family physician. Talk to us what it's like to be a family physician in 2024. I know a lot of us actually in this room might actually run to you after and say, could you be my family physician? Could you sign me up?
Yes. Yes. So that's interesting because I do get that question a lot. So for me, I actually fit under where Alika said, which is that I'm qualified. So I'm double certified as a family physician and as a specialist in public health. So my primary care work doesn't involve having a regular practice, but I do see patients aside from also looking at things from a population health lens, particularly an anti-racism lens. So what I can say that, you spoke to the question before, have things gotten worse or better? I can say from the primary care end, as somebody who, probably for over a decade, I've done house calls. So that wasn't in my bio, but I do house calls in community, almost like the reverse of a walk-in clinic. So for people who are seniors, for people who have low mobility, I do that with MedVisit. And, having done that since, 2010, 2011, what I noticed post-pandemic is that when I would go see seniors and be like, okay, we can change this medication for you, we can do that, but you're going to have to go back to your family doctor. Sometimes I would hear people say, oh, my family doctor retired. And then, we'll talk about how I can provide you that kind of care. But what I have heard, particularly in the region where I do most of my house calls, which is Scarborough, high needs area in Toronto, is people saying the clinic is gone, right? That's very different than the doctor retired, which is what I would hear from time to time. I heard lots of people saying the whole clinic has disappeared. And so from a primary care standpoint, that's devastating, and it became really difficult to help people navigate that, especially people who are in their homes. And after a pandemic where we actually learned how to help people more virtually, it was particularly devastating and difficult to be able to navigate. So I think there are certainly areas where we are objectively in a worse place. And I think in the context of crisis, I think the other thing that we need to think about is that we found very innovative ways to do things that in healthcare we had previously said were impossible during the pandemic. And I worked with Black communities and Indigenous communities, and we found very amazing ways to provide humanistic care that wasn't just about the vaccine, but about real connection. And I think we need to tap into that and hold on to those pieces that we applied at the height of the crisis that I think as people want to scurry back to status quo, we need to have a resistance for that, and we already have some promising practices that can help people who are, in home and cannot leave, but also with other marginalized groups as well.
That's wonderful, and we'll get back to that because that's a key theme of your closing, where you talked about how crisis is really the impetus for change. Douglas, you're in a unique situation. You're a Canadian born and bred, but then you moved. How long have you been outside of Canada?
So I moved to Boston for a one-year postdoctoral fellowship in Harvard. I never made it home.
How many years ago?
What was that, 92 till now? So it's that.
So over 30 years. So Alika started with the importance of stories. And as humans, stories define us because stories are how we take in information, how we see the world. And they're also how we look at kind of solving problems. One of the stories that we used to tell ourselves when you were still north of the 49th parallel is that we have this incredible healthcare system, the envy of the world. In fact, the story was so deeply ingrained in us that I think it's not even unfair to say that it was part of the Canadian identity, that healthcare is part and parcel of what it means to be a Canadian. Does it surprise you as somebody who's kind of gone away, not too far, but gone away, that now we're having a kind of a national angst about the quality of healthcare in Canada?
Well, we are Canadians after all. So I did not move to the States for their healthcare system. Their healthcare system is abominable. So we look at the stats in Canada. 1 in 5 don't have access to primary care. In the States, it's 1 in 3. That means 110 million Americans don't have access to primary care. 110 million, 3 times the population of this country has no access to primary care. So it's a staggering, if you look at the scale, it's just staggering. So I still believe that Canada could and should have the best healthcare system in the world because you have the right balance between the public, the private sectors, and civil society. And in America, the public sector has abdicated their role in providing health. They don't see health as a right, whereas I do, and I believe most Canadians do. And that means we have extra levers that we can pull. My contribution to the system is through the private sector. I help develop drugs that will keep people out of hospital and will reduce costs, which is a very, very good thing. But the only other way I can have influence in America is by being an elected official. So I'm an elected official in my little hometown. It's in very rural Pennsylvania. They are not pro-healthcare, to say the least. And we do not have an emergency care facility in our entire county of 54,000 people. And the only way to make that happen is for me to basically work with the private sector to somehow convince them it is worth their profit motive to move to our little place, and it is almost certainly not going to work. So more to be done, but I tell you, you have all the levers here. It's just a function, as was said so eloquently by our speaker, to just make sure that people are firing on all pistons.
Now, we haven't talked about the M word, and the M word is money. Now, as the president of the Canadian Medical Association, I'm sure you must have advocated for more money. Is that the solution to our problems, more money?
I think when we look backwards at change that's happened, we sometimes retcon the past and imagine something different than what existed at the time. For example, when the CHA, the Canada Health Act, first came out, it wasn't the 5 pillars that had everyone snap to attention and suddenly everyone was working together. It was a vision that we could do better. And so the CHA hasn't actually been very effective at all in getting anyone to work together. There's only been 2 parts of it that's actually gone to court to be interrogated. There's very, very different approaches to how you get compliance and what is compliance or interpretation of compliance. But it was that vision of people coming together and that for the first time they actually could have a national healthcare system. I think we're at the beginning of a new cycle. You know, or a couple of years ago now, the budget before this last one, the federal government did invest the highest amount in healthcare ever since the health accords first started in the early 2000s. And so we have that spark that I think could lead to people adopting a common vision. Money in and of itself is just a tool. And so if that tool is used in the right sort of way or is put in the right sort of hands, absolutely, I think we could solve our big problems. But the question is whether or not there'll be a vision to go along with the tools. And I think that is what a lot of us are still sitting here waiting to see.
I'm going to ask you each to answer in one word, yes or no. Alika said the system's on fire. Yes or no?
Yes.
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 So when something's on fire, our natural inclination is to run. Should we run or should we, and I mean run in a different way here. Run is, I think in this sense, it's like, should we go to the United States to get our medical service? Should we sign up for private clinics? Should we bake cookies and other things for anybody who we know who's a family doctor to try and get them to like accept us? I kind of go this way. You said yes. A moment ago you said that we're still far better than the United States, if I heard you correctly. But if we're on fire, like, oh my God, like what is it outside of Canada then?
Well, here I'm going to harken back to my dad. So he taught me that good things happen because of leadership and bad things happen because of leadership. Mm-hmm. And not everyone's going to run into the burning building, but leaders do. And they save the people and or put out the fire so more people survive. So I think the clarion call to this audience and a lot of young people here is, you know, amass as many personal tools as you can to have as much influence as possible and run into that burning building and fix it. And if you look, for instance, the CMA put out a great paper in 22, which gave a roadmap of how it is that we could fix our problem here in Canada. It's just a function of having the leadership and the intestinal fortitude to execute.
That's a big word, leadership. We'll come back to that one. Why are we on fire?
Why are we on fire? I think, again, Alika spoke to it. It's just we had a healthcare system. A lot of people say that it's broken, but it's performing in the way that it was meant to perform. It's just not relevant for our needs today. So I think that's a huge part of why it's on fire, or that we're noticing that it's on fire. I think it's been on fire for a while. But I think part of the solutions that we need to think about, you talked about young people running into the building, is also thinking about, I'm coming back to the marginalized groups. We come from communities that have been on fire. Yeah. We know how to thrive in conditions of fire. And I think the question is, and even from public service or for leaders, is when you're at the table, first of all, are we there, those of us who know how to navigate in difficult, circumstances? But on top of that, when we say there's 5 Fs and you think there are 3, are you willing to listen to the fact that there are 5 Fs and move towards those innovative solutions? That's tough in leadership, right?
That's really tough because it's really tough because we're in a world now where leaders, because Douglas brought up the term, leaders are having challenges. Leaders have a kind of a credibility gap almost by definition. Like, I think it's fair to say when we were younger, if you were a doctor, you were automatically unquestioned. Like, the doctor says this, you have this. Now it's kind of, well, I might have this, I might not have this. I looked on Google, I talked to my aunt. I was on in a chat room yesterday, and I posted what I've got, and they told me your doctor is insane, la, 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 la. How do you be a leader in 2024 in this field, given everything's on fire?
Yeah, so on fire is an interesting analogy, I think. I want to go back to the pandemic, and I want to go back to something Alika said, because I think there's an element here where we had a major crisis in the middle of the pandemic. And what I saw personally was we've never had a problem, based on the last comment, we've never had a problem in this country with tremendous leadership and innovation and research and really trying to drive change. I think the perspective of everyone saying going back to the pandemic was not a great place to start. What we saw in the pandemic is all the bureaucracy, all the traditional silos, all public policy, it kind of went out the window, and there was a focus on managing one population, which was COVID. And the amount of innovation that happened was incredible because it was in the middle of the crisis. The crisis ends, everything goes back to the way it was. We really didn't implement anything we learned through the pandemic. And so I think part of, to your question around, from a leadership perspective, what we have to do is we have to realize that we do have significant challenges. There is pockets of things that are on fire, that are crises, there are pockets of things that are working well. But what it requires is a lot of leadership to drive change that is not going to be tremendously popular. But if we're focused on truly the most important body in this entire thing is the patient and the family. It's not the hundreds of associations and all the providers. If we're going to focus on what's right from a patient perspective, that means we have to systemically change, which means at best 80% agree. But if we try and find consensus and leave it the way it's been traditionally, I think to Alika's point, we will continue to see pockets of fires and greater challenges. Personally, I think within this region and with this country, we actually have a very good system. We just have to play a lot greater leadership role at all levels on driving a change that's going to create better sustainability. And sure, you need more money, but I'll tell you the amount of inefficiency within this system is enormous. Yeah. And so there are ways to drive that out.
Now, Zaina, all 5 of you, including you, said that the system is on fire. Talk to us a little bit about...
Well, yeah.
Maybe
I was going to make a joke. So when things are on fire, as normal, rational humans, we would run it or whatever.
Yeah.
In Canadian healthcare, what do? We commission a study. We study it again for the same conclusions. Because anyway, that's what we do. So I think we absolutely do not need another penny in Canadian healthcare. We actually can't find it anyway because we're already 75% publicly funded, and we can't get taxed anymore. So there is no more money. So I think there's 2 things. The only thing everybody universally agrees to is kind of what we've heard. You as Canadian citizens, the financiers of the system, the people who are the users and the beneficiaries, if you don't pull us to the future, I think all the leadership in the world is never going to get us there. And I don't think Canadians are angry enough yet. They're not demanding more, and they're not pulling us to the future. So I think we're close, but I think that's going to be the lock and the key. In parallel, this whole conversation about leadership. So to me, the lever on money is set the conditions under which the public sector will pay and make people accountable to deliver care that we all agree we want under those conditions. Right now, we pay for procedures. We don't pay for the result. And I think until we start having way more accountability, like under the Canada Health Act, I think we're just going to have a free-flowing money, and who's going to always suffer is going to be our patients.
Alika, you said that in a crisis, we create change, which I think is true. You also said that we come together on a singularity of focus, and I think a few of you have brought up that your concurrence with that. But there were some things that we saw that were the opposite of that during a crisis. Like I always kind of imagined, if things ever got really, really bad, tribe A and tribe B, and everybody would kind of put their differences aside and we would all pitch in, when the Martians landed, the Americans and Canadians and Russians and Chinese, we would all it's a worldwide crisis. It didn't really work out like that. Like, did it feel like that from inside of a hospital to you guys? Like from outside of the hospital, it kind of felt like the pandemic, probably the greatest crisis, public crisis of our lives. It felt like it accelerated and differentiated difference rather than bring us together. And I'm curious why, or what it was, the hopeful thing that made you say that, this brought us together and we will continue moving forward.
Yeah, I think the flow of crisis is not evenly distributed first, right? When Catherine Smart, my predecessor at the CMA, said on Power and Politics, our healthcare system is collapsed, and it started off a firestorm where pretty much everyone said, this is not true, you're overreacting. I inherited that, and over time people realized, no, she was actually right. And the reason why is because collapse is not evenly distributed. Right? Just like the calculus of suffering is never evenly distributed across a society. I think one of the things to remember about crisis is that it both breaks and builds systems, right? And so crisis can break relationships, it can break trust, especially when you're gaslit, which I think was a lot of what happened during the pandemic. Originally, it was a command and control structure because we really did have this unknown pathogen. We didn't know how it was spreading. I mean, I slept in the garage for a little bit after the pandemic was officially called because I didn't want to get my family sick. And there were lots of us who were living at the hospital because we were thinking to ourselves, well, I'll just be around in case somebody needs help, right? Now, with subsequent cycles of meetings and other things where we gave our lived experience and offered our expertise to fix things, a lot of us realized by wave 3, 4, and 5, no one was actually interested in changing anything. And so at that point, we stepped back and said, well, if the house is on fire and there's nothing I can do to help with it, I'm just going to make sure I don't get burned, right? And I think that that was what happened in the course of the pandemic that really took things south. When the instruction was given to the public not to wear masks because masks didn't work, that had nothing to do with science. That had everything to do with managing inventory. But instead of being honest with people and saying we don't have enough to go around, they instead said something else that wasn't true when you actually interrogated the information. I think we took too long to come out of lockdowns. We know that. And instead of just being honest with people, instead of giving them these complex solutions and helping them come along with the story and be brought together, we told people that once they interrogated a little bit more closely, they all realized, this doesn't actually feel right. And the truth is, crisis is complex, it's messy. We don't actually know what's going on. I see smoke coming out from a plume that's, 30 kilometers away from me in Grand Prairie. I don't know which direction that fire is going. I have to go turn to someone. I have to trust them. I have to trust their assessment. And, I think forest fires are an interesting experience in understanding how to manage crisis because in Grand Prairie, lots of people have their own heavy machinery. And people were going out trying to build these barricades, but they were creating more problems than they were fixing because they didn't know how to do it properly, right? And so even though you have the willingness and the thought that you know what you're doing, you still need leaders. You still need people to buy into shared truth and shared approaches. And I think that that's really where crisis goes off track, is you lack these shared types of understandings, the cohesion that it takes to have us work together. And then you have this arbitrage of the crisis, where entrenched special interests come in, they take all the momentum that you built, and they walk away with what they need, while the rest of us are left with little if nothing.
I love that notion, Alika, that crisis both builds and breaks. It reminds me of William Gibson, who said, that the future is already here. It's just unequally distributed. It just depends where you look and you'll see the future. Anya, I want to ask you, in the myriad of kind of issues, good and bad, that we see in the healthcare system, and Alika, I'm going to ask you again for your community. You have a particular expertise and focused on healthcare vis-a-vis racialized peoples, and even more specifically vis-a-vis Black Canadians. Can you talk to us a little bit about, with all the challenges that we see in the healthcare system, are some populations even more disadvantaged interacting with the healthcare system? Do they carry even a greater burden than the rest of us?
Yes.
Next question.
Yeah, absolutely, but how so?
Yeah, I think, what a lot of people might not realize is that in the formation of like Western medicine as we know it, in the way that it is taught, so much of it kind of focused, let me say, the gold standard patient was like the white 70-kilogram male, and all of that comes with that. And you can see even for, let's say, white women, right, either misunderstandings, biases, and all types of things. We've seen the studies that if a woman has a surgery with a male surgeon, so this is not even about race, she's 30% more likely to experience death from that surgery compared to if it's a woman surgeon, right? And we don't know all of the reasons why. So now take that. So that's just gender. And then on top of that, if you add race and the biases and stereotypes against focus on Black people that actually stem from our history of slavery in Canada. Yes, we had slavery here, not just in the United States. But the things about us that, we're less intelligent or not to be trusted. So when for instance, a Black woman is pregnant and presents and says, I'm in pain or something's happening, she's less likely to be believed. She's less likely for that physician to understand the complexity of her situation, not that she's biologically different. We've mapped the human genome where there's no biological race, but her lived experience, the stressors that she's under, her context, that's a complexity that a lot of physicians are not taught about or actually provided misinformation, right, about different groups. And so that leads to worse outcomes in healthcare. Racism kills people, and in healthcare, it's no different. Healthcare providers have biases. And, if we think about the Indigenous example, or if we're thinking about Joyce Echaquan, that was a key case that, people reflected on. So time and time again, Black folks, Indigenous folks, racialized folks experience really poor outcomes in healthcare, not always, but either due to intentional or unintentional biases from healthcare providers who are just part of a regular society where there are those biases.
Alika, you're kind of on both sides of this. You're an Indigenous person, and you've seen out west in particular how Indigenous communities are treated vis-a-vis the healthcare system, but you're also a healthcare provider. Is there something that you've seen on either side of those two sides of the coin that has particularly struck you?
My dad used to teach me when I was younger through parables. So he'd say, you have a researcher, you have an advocate, and you have a community organizer all walking down the street together. And they see someone who is homeless. And the researcher counts, the advocate yells for someone else to help, and the community organizer sits down and sees whether or not they need medical care or provides them food. And I think one of the biggest challenges that talks about what Anya was referring to is we're all waiting for someone to tell us, oh, this is a big enough problem for us to deal with things, instead of just recognizing we can see it, right? Each of you in the audience probably has a personal experience or has one relationship, a way of knowing someone who did not get access to care even though they needed health care. And I think the challenge with being a provider is knowing when your story ends and your patient's story begins and kind of getting out of the way of people being heard. It's also knowing when you can't do anything to help. Anesthesiologists are the medical ninjas of the healthcare system. We're highly specialized. We're dark and mysterious.
By the way,
we're the last thing you remember before you lose consciousness. But there's There's certain things that we just can't do, right? I can't function as a family physician. There are surgical things that need to get done, but I know that when ORs get turned over, I can mop the floor, right? I can go grab the patient because the nurse is busy and doesn't have time to check in the patient. That can save me a whole case or two. That stops someone from having to be in a holding pattern of having to need care again. And so I would really love to see in the future of healthcare, once again, we need a vision, we need a leader or set of leaders who are committed to working together. Because the provincial territorial system of these isolated approaches, it will fail. We know it fails. That's what every part of history tells us with these big problems. To bring us together and then just start doing things. We need this age of action where we all just go out and start doing what we do well. And I really do think the public service is going to be a really big part of that, because the stories that you believe become the stories that we believe, right? Because you're the ones who create that narrative for new political leaders. You're the folks who listen to lived experience. You see from a broad, 40,000 foot vantage point, what's working and what's not. And we desperately need that in healthcare right now.
So we've come to the end of our time, almost. So I'm going to ask each of you, and I'm going to start with you, Douglas, to kind of give us final thoughts. Give us either a prescription or a little bit of hope, be a Pollyanna, be a Cassandra. Close any way you'd like to close in terms of talking not just to the people in this room, but also to the people who will be watching this on our website over the years to come.
Well, if I could start, I just want to say you honor my father, and I'm really appreciative, as is my entire family. And I'll quote my dad yet again, right? If you don't have dreams, you have nightmares. And you might as well just make up your own dreams.
I like that a lot. Anya.
Yeah, I think, I'm thinking about, again, in Alika's slide, the piece around hope, right? And I think that's where we need to anchor ourselves. And in that understanding, as was discussed earlier, that we're all connected. And so for me, I think that the piece, again, that we used when we were, working in community and the vaccine clinics and working in collaboration, but also bringing our different cultures into the mix, a lot of us used the South African principle of Ubuntu. I am because we are. And it was necessary not just for our patients, but it was necessary to do that with our providers, to recognize their humanity so they were better positioned to be able to serve others. And I think that applies to the public service and anywhere that we are working and connected together, we have to see the humanity in ourselves and the humanity in others. So for me, this work, the hope for me is anchored very much in Ubuntu. Thank you.
Cameron.
So I do think there's a hopeful future here. I mean, I've been doing this for close to 30 years now. We've been through dozens and dozens of crises. And while we often reflect on what we need to improve, what you need to do from a leadership perspective, we often forget of how many things we've done well and the strengths we've built in a healthcare system. So I do think we're starting from a foundation that has a lot of strength in history. I do think, though, that regardless of what happens with governments, within communities need strong leadership to continue to build healthcare, regardless of what happens with government. And I think when you look at the leadership that exists within healthcare, it doesn't matter whether it's in a hospital, whether it's in the community, whether it's with physician leadership, it's how do you rally that engagement? Because what's interesting is when you talk to whether it's patients, physicians, nurses, everybody completely agrees there's a way to make it better. What we need to do is rally people to make it better. And you can't wait. The worst thing to do is to wait for someone to fix the problem. What we need to do is stand up and fix the problem within each community.
Sane.
My message, I think, to policy makers or influencers is obsess about creating the future, the new story that Alika talked about, that pull to the future, instead of protecting the past. And we just heard the weight of the past, the inertia, it is in the DNA. So when you catch yourself doing stuff that's going to propagate the very thing that we just said no longer serves, I think that threatens the survival of our healthcare system. So create the future and don't protect the past.
Mr. Ninja, you get our last substantive word.
I truly believe that what we need for leadership has shifted. And I remember what my parents tried to instill in me when I was young, which was regulating inside myself and not worrying about the world and everything that was going on outside. I mean, I grew up feeling like I was broken. I was labeled with a learning disability. We experienced racism growing up. I didn't really feel like I fit in anywhere. And it was that grounding in understanding who I could change and the emotions I was going through that really helped to ground me. But that's also led into a leadership skill where I can help other people ground each other. You know, anesthesiologists, they're peacemakers in the OR. When surgeons fight over what case to do at 3 a.m. and they can't agree with each other, someone who does anesthesia well walks in, disappoints everyone, but everyone actually feels better. That usually involves pizza. But I think that that's what we need from our leaders. We need people who themselves know how to self-regulate their own emotions, and then people that can manage conflict. And so if you see leaders like that, I really hope that you lift those folks up. Those people will be who will lead us out of this crisis.
Yeah. Now, I can't let you go yet because somebody's going to give formal thank yous. But I want to, on behalf of the audience, give you all a round of applause. But sit still, don't move, okay? This was the 27th annual Mannion Lecture. The 28th annual Mannion Lecture will be given by somebody in the audience. If she's here, she can stand up. It will be Madame Jocelyn Burgon, former Clerk of Canada's Privy Council.
So before I turn it over officially to Vanessa to close and conclude, I just want to take a moment again to thank our esteemed panel. Leadership matters. You are incredible leaders, and just a few things that I noted, if I may, which were really your takeaways. If you don't have dreams, you have nightmares. I am because we are. Leadership matters, so stand up and fix it. Create the future. Don't hold on to the past. And finally, the importance of lifting one another up and the importance of connection. So thank you. Over to Vanessa.
Thanks, Nat. And thank you to our panelists. Thank you to our guest lecturer, Dr. Lafontaine. Thank you, Taiki. Thank you to the team who worked behind the scenes to make today's event happen. Thank you all for being here with us today in person. I also want to share a few of my takeaways, if I may take a few seconds. Douglas, running into the fire, run towards the danger. I'm going to take that away. Run towards the danger with the right team, to Anye's point. And then once you have the right team and the right people, listen to them. Have the courage to actually listen to them and take on what they're saying. Have the courage to listen to the crisis itself and the wisdom that is in that crisis and what it's trying to impart to you in that situation. Get angry. Get angrier, to Zaina's point. There's a lot of wisdom in anger, and it can be channeled as fuel so that we have the courage, as Cameron said, to keep the main thing the main thing. Focus on the patients, focus on our families, our communities, and the prosperity and health and wellness of Canadians. So with that, I hope that the Polycrisis talk has been inspiring, and we are creating a story that pulls us towards the future, which contains hopefully poly opportunities for us. And to officially close the Mannion Lecture this year, we would like to welcome back Elder Verna McGregor to send us off in a good way.
Way again, I have to send you off in a good way. Usually if I was in a lodge, we'd send you off with a little honor song. But I'm going to ask you to maybe join in because you have to earn your juice outside. I'm going to sing a warrior song because I think all of you are warriors and need to be honored. And I'm going to sing the first part, but the second part is we'll just have a practice. So the second part goes like, ya, hey, ya, hey, ya, hey, ya, hey. You think you could do that? Let's try it. Ya, hey, ya, hey, ya, hey, ya, hey. See, we're going to get on YouTube after this. So you sound wonderful, so follow on. So just really quickly to close, and it's to honor all of you for the work that you do, because I know you usually go above and beyond. So here we go. It goes like this. Oh, this is my rattle, and we call that sheshigwan. And we use that too as well in healing ceremonies before, and it represents also like the rattlesnake. And if you look at the Canadian Medical Association, you see the two snakes intertwined. It represents too, for us though, is snake medicine is one of the highest forms, and I'm here very honored to be amongst one of the highest forms here in the medical profession. So here we go. Are you ready? Let's go like this. Hey ya, hey ya, hey ya, hey, hey ya, hey ya, hey, hey ya, hey ya, hey, hey ya, hey ya, hey ya, hey. Hey ya, hey ya, hey, hey ya, hey ya, hey. Now here you go. Here comes the crisis. Are you ready? Ya, hey ya, hey ya, hey ya, hey. One more time. Ya, hey ya, hey ya, hey ya, hey. Hey ya, hey ya, hey, hey ya, hey ya, hey, hey ya, hey ya, hey ya, hey, hey ya, hey ya, hey, hey ya, hey ya, hey. You all sound wonderful. Really, what I sang is a warrior song, and a warrior is not somebody who picks up the sword in battle. A warrior is a person who looks after the community. And when you saying, yeah, it's alerting the community that there's danger and something needs to change. And that's what we've all went through also with COVID. So have a good evening and drink lots of juice.